This is the case we've looked at previously that Peter Endo sent in. It's kind of an interesting case, and I'm going to let him narrate it, but briefly here. It's a lower bicuspid with a fairly large area around it, and necrotic. And he went ahead and filled it in July and placed the patient on recall. Patient had an uneventful recovery. But then in December, the patient came back with symptoms and enlarging lesion, loss of the buccal bone, and findings that suggested perhaps a vertical fracture of the root. Peter's final report recommended an extraction and a placement of an implant. When I got the tooth, I didn't see a vertical root fracture. I sectioned it sagittally, as is our method, and got a pretty good look at the root. Got two fairly good sagittal sections, not perfect, but enough to examine the canal. I was able to tease the gutta percha out. So after they were dehydrated and dried, these are what the specimens, the two halves, look like. And we're going to examine them in several areas. These are what the sputter-coated sections look like, and I urge you to go to the site and try to compare these and correlate both the wet, dry, and sputter-coated sections and see if you can actually detect where we're actually looking. We're going to look basically in two areas today, one near the terminus on side B and one near the orifice, more coronally in the orifice opening. So the two sections, area 2 will be right near the terminus, and area 3 will be up near the orifice level where there's a clean dentinal wall. So when you go into the site, go into the stitched images, and I'll kind of walk you through that. We're going to look right at area 2, right at the terminus of the canal. And I've outlined the stitched area there so you get a pretty good sense of where the stitching occurs. I think this is some of the best stitching I've done since we started this technique. So that's the area of interest that we're going to look at. And when you actually go into the stitched image and zoom in on it and look around, you can see a fairly extensive biofilm present, some demineralization of the mineralized front, but a lot of biofilm matrix present, and what appears to be suggestive of a candida, fairly heavy candida infection. And so it's worthwhile taking some time and using the stitched image and really take a look around and see what you can detect. I see a lot of biofilm matrix as well as some demineralizing smear layer and demineralizing mineralized layers. So it's clear that Dr. Endo did use some EDTA on this case as well. But when you go into it, you can see what appears to be candida-like organisms on the mineralization front with still quite a bit of matrix. And when you go in and look at, I've included some of the literature on candida infections on the scan electron microscopy of candida infections to give you a better sense of what they look like from other authors. And they have a fairly characteristic appearance, although they're very pleomorphic and capable of many, many different kinds of shapes and sizes. So when you go in and you look, it seems to me there's quite an extensive candida-like infection at the terminus. Now, when you go up into the area 3, up near the orifice, the picture changes dramatically, and you can find no candida-like organisms there at all. And you see just basically the mineralization front, some minor smear layer, but most of it has been removed and demineralized. And you see many open tubules that are in a partial stage of being demineralized. And when you look carefully at the dentinal tubules, you'll see that still a lot of the peritubular dentin is still present and it has not been demineralized. And you can see there's probably some predentin there still that hasn't been removed. But all in all, a very, very interesting case. And I'm looking forward to Peter coming and narrating how he thought about this case clinically.